Well, the UK has been affected a lot, as I think the whole world knows. The UK has it's the national healthcare system in the UK. It's a very robust mechanism of a healthcare system, but it has its restrictions, it has its limitations. It's a huge, sometimes I say it's like a big elephant trying to turn, or like a big tractor trying to turn. Yeah, it's not extremely flexible. So when such a high challenge like the pandemic comes, it brings a system like that to its limits. So we had a lot of issues with capacity. We had, as within the British Gynaecological Society, and with the help of Sudha Sundra, the president, we're very lucky to be able to sit together virtually and make some not guidelines, but some stratification of patients who to operate immediately, who should or could wait, so that we make space. A, we make space, and B, we don't expose patients to unnecessary risks while being at a hospital for having an operation that they don't need really to have. So we issued some guidelines about the timing of operation in advanced ovarian cancer. We were more towards neoadjuvant chemotherapy. We tried to set back secondary debulkings, big excentrations, unless it was an urgent reason for palliation. Very, very early endometrial cancers, we treated them conservatively with progesterones and Mirina's. So we tried to find the best surgical candidates for the limited space we had, plus without exposing the patients to unnecessary risks. I mean, when the pandemic started, we didn't know how terrible we didn't know how the impact of a COVID infection perioperatively is. And what we have also managed to do is, again with Sudha, I was very privileged to be able to do this work together, was the COVID surge project. This was a project where we collated all the perioperative data from gynecological cancer patients throughout the world, and see how they did, how the perioperative mortality, morbidity was while operated during the pandemic. And these are data that I hope we can present to you in the next couple of months.